Good afternoon, everyone, and welcome to It Takes a Village to Stay at Home Safely, presented by the Visiting Nurse Associations of America. Before we begin our program, I would like to highlight a few housekeeping items. Today's webinar will feature a lecture, followed by a question and answer session. During the presentation, all participants will be muted. However, you may submit questions to the faculty at any time by typing them to the chat feature, which is located to the lower right corner of your screen. We will conduct a question and answer session at the end of the conference call via the chat feature in order to allow the faculty ample lecture time to cover the material. Following the webinar, each registered participant will be emailed a copy of the slides. As a reminder, today's call is being recorded on Wednesday, August 10th, 2016. I would like to turn the presentation over to Beth Glasheen Wray with Christiana Care VNA. Mary Beth?
Thank you. Thank you for joining this webinar. We have enjoyed bringing this project to fruition and continuing to make case conferences part of our practice. What I'd first like to do is introduce our speakers. And my name, obviously, is Beth Glasheen Wray, and I have been a physical therapist for about 40 years, the last 28 in home care, and I currently am a rehab manager for the last 7 years at Christiana Care Visiting Nurse Association. Our next speaker, Andrea Huertas, she was our skilled nurse, clinical director at Christiana Care VNA while we started this project, and is now an educator in New Hampshire. And lastly, Naomi Price has started as a scheduler interacting with patients and clinicians and really enjoyed the interaction, and is now an executive assistant who wanted to continue her role with case conferences and is invaluable to the setup of the conferences, sending out emails and moving along the flow of the conference. Oh, sorry, went the wrong way. Okay. We'd like to first talk about what size of a healthcare system we are and tell you a little bit about us.
Thank you, Mary Beth. Christiana Care Health System has primary care office visits statewide in Delaware that equals to about 227,295. The VNA itself has home health care visits in excess of 312,000 annually. The system's admissions are ranked 21st in the nation. Surgeries were ranked 29th in the nation with over 38,000. ED visits for a small state were ranked 21st in the nation with over 187,000, and for births we were ranked 32nd in the nation. The VNA itself covers the entire state of Delaware, and again we have about 312,000 visits per year. With that, we have 638 employees, and our territories include the entire state of Delaware and some small areas in Cecil County, Maryland. In the state, we have 2 branch offices, both in Newcastle and Kent counties.
What we want, everybody is familiar with case conferences, and that's really not anything new, but we wanted to look at if we could change the method on how we were conducting our case conferences. We wanted to be proactive in how we worked with our patients and making recommendations, and not reactive in particular to our complex patients. We started with, excuse me, I'm sorry. So what we wanted to do with our presentation today is we wanted to go over the objectives. We wanted to describe the progression of case conferences, how they moved from 30 to 60 minutes to 5 minutes, define the flow of case conferencing, and discuss the impact on hospitalization, describe the efficient use of SBAR, and discuss our path forward.
So I guess that's me. Thanks, Mary Beth. It's Andrea here. So just to give everybody a little bit of information in regards to just some background and knowledge, you know, as everybody on this call knows, one of the most important and significant things that we bring to the table is to really work with our patients to assist in keeping them out of the hospital. So the whole concept of acute care hospitalization, really important to the hospitals, but you know, also when we did some research and looked at the RAND organization, on some of the things that they published, what we found was that it's also really important to our patients. The majority of our patients, when you really ask them about quality of life and the hows and whys of what they want to remain in their own homes. So the acute care hospitalization, from our opinion, was really twofold. Yes, we're going to help the hospitals, we're going to help the home care agency, but most of all, we're going to help and respect what our patients want. So Christiana Care visiting nurses, what we looked at is, go back, Mary Beth, one slide.
Okay.
So what we looked at was we actually have an objective tool. We use SHP, Strategic Healthcare Programs. We use them to do the analytics, and we use that as our benchmarking tool. So it actually takes the data, looks at what our Medicare patients are doing, and also at the same time, it tells us about the acute care hospitalization, but then it also tells us about you know, how they are screened and if they're at risk for hospitalization. So it's a really complex formula that SHP uses, but that's the tool that we use to capture this data. So then the next part of our background is we looked at case conferencing and we said, okay, so, you know, all of us have a format of case conference that we use. We actually used SHP, and we captured who our high-risk patients were for rehospitalization. And then what we did was we actually implemented how we were going to begin to case conference about these patients. Some of the logistics for case conferencing that have been challenging over the years, our clinicians are off-site. You know, we want them to be productive. We want them out seeing the patients. And then how do we bring them to the table, and how do we have them be included in being able to best meet the needs of discussing patients and how we can move patients forward. So we identified the need for case conference, that it needed to be often, and it needed to, you know, occur when people were being discharged from the acute care setting. So the sooner we could case conference, the better our anticipated outcomes potentially would be for patients to keep them out of the hospital, keep them in their own home. So, you know, as Mary Beth alluded to early on, when we started case conferencing, we were so excited because we were case conferencing approximately anywhere from 30 minutes to 60 minutes. And it was really around the clinician's plan of care. And, you know, as many of you in organizations know, what we ended up case conferencing about a lot of times were the psychosocial pieces of the patient, and, you know, how those psychosocial and economic pieces actually affected us as clinicians. And so we really needed to change the focus. So Christiana Care visiting nurses had a tremendous amount of support to elicit the integrated care management model. And I'm hoping that Beth Hennessy and Paula Sutter are on the call. But, you know, we really embraced integrated care management, and the organization really focused on getting all of leadership educated, and also all of our field staff educated and certified in the integrated care management model. So, you know, as you can see, or you can't see yet, haha, but you will see, our baseline data was pretty incredible. So the overall ACH risk-adjusted rate for Christiana Care VNA in fiscal year 2014 was about 25.11%, as compared to national, which was 23.70. So remember that. We were at 25.11. National was 23.70. Then what we did was we also looked at where we were as a comparison for our alerts for hospitalization. And like I said, we actually used SHP to capture that list of patients as to who we were going to be case conferencing on and why. And so, you know, we alerted, Christiana Care VNA, we alerted at about 34.2%, and national was about 38.1% that were triggered and alerted at started care for high-risk rehospitalization.
So we knew that we wanted to start a different type of case conferencing based on the ICM model. And as Andrea said, the managers and clinicians were included in this training, so that we wanted to have all the disciplines at the case conference. We identified the moderate to high-risk patients by our SHP tool, excuse me. And we also we had educated our clinicians to SBAR in preparation so that we could keep the discussions very focused. It's a lot of things would come up that were really out of our control, so we wanted to really stay on top of what were the pertinent information. And discussion often lasted 30 minutes per patient. And if we wanted to make an impact on hospitalization, we really needed to do more than 3 or 4 patients a week so that we could have high quality care planning. And we also wanted to be, and we couldn't be sustainable if we were only going to do 3 or 4 patients in a 2-hour period. So in January, Andrea presented the baseline data. We did some piloting with the case conference, so we really kicked it off in January of 2015, and after we had completed the training. And the goal of the education was to be meaningful, timely information exchange through SBAR, and we really wanted to focus on the patient's goal, not the nurse's goal to decrease blood gases, or excuse me, blood sugars, or the therapist's goal to decrease the TUG test. The case conferences, after having done the pilot, we resumed using our new skills, and our new skills focused on proficient use of the SBAR, as well as the key ingredients to effective case conferencing: good planning, good structure, good facilitation. And we wanted to make it something that it was worthwhile for the clinicians to take the time to participate in. So we had the list of patients. We had our list of patients that were on the agenda, and that was communicated the Thursday before of the previous week via email to the managers and clinicians so that we could hold case conference on Monday. And each conference had a designated time allotment. Now initially we really encouraged the clinicians to come into the office so that we could have that face-to-face time. However, as we improved with our time, we then set up a conference line so that they could call in. And as I said, we used the moderate and high-risk patient for our case conferences. However, it was also, if a clinician was struggling with a patient, whether it be acuity, social situation, needing assistance with which direction they needed to go, they could be added to the list. And it gave the clinician a sense of another resource to help them with the care of the patient, particularly our complex patients. Staff also on the email received written instruction as to how to prepare using the SBAR, including video examples of effective and ineffective communication during case conferencing.
So the next slide here shows an example of the email that is sent out weekly to our clinicians. It lists 2 hyperlinks to effective case conferencing as well as ineffective case conferencing. In addition, it lets them know what the SBAR is, reminds them that they need to send that in their absence. They should send that to their managers so that their managers can discuss the patients on their behalf. At the bottom of the email, it includes the table that shows the patient's name along with any clinician that has seen that patient or that regularly sees that patient so that they're able to come prepared and discuss the patient as well. On the next slide, it shows just a quick example of what the SBAR is. And again, we send this out to our clinicians. It lets them know that the situation, the SBAR, what it stands for. Situation, give us a brief description of what's going on with the patient, their background, any pertinent medications they may be on, or any pertinent medical history that we may want to know. The assessment, what the clinician's assessment of the patient currently is. Sometimes that includes the assessment of the caregivers as well. And the recommendations, where we want to go with the patient to help them reach their goals.
So then the good structure, we'll move on to good structure, and that requires that we begin the meeting and it begins and ends at a certain time, and we stick to that. We usually have our case conferences in our boardroom so that we can have the medication list projected. There's usually a few other people who have laptops so that we can be looking at if there's a particular concern about a certain area that we want to look at. For example, one of the things we learned with hospitalization, it seemed to be that our oncology patients and cardiac patients were most likely to go back into the hospital. So when we looked at some of the functional questions, the M1800s, we would see that they would score very low, but yet therapy wasn't ordered. And so we would be looking at various pieces of the chart. As I said earlier, the focus of the case conference is on the patient's goal, the patient's stated goal, and how our plan of care can help them. Somebody might want to dance at my son's wedding, or they might want to return to the senior center to mingle, travel to Europe before I die, so that we could help motivate the patient and give them the confidence that they needed so that they could make the changes that were necessary for them to have their good health. Good facilitation. We really wanted to keep discussion related to the SBAR. We sometimes had to very politely cut people off to keep them on target. We might want them to limit a lengthy past medical history because it wasn't always necessary, and we wanted to concentrate on what was the problem now and what did we need to do to keep them out of the hospital. We wanted to facilitate learning and provide ongoing mentoring, especially for some of our new employees. This was a different way of doing case conferencing. We wanted to wrap up the discussion with recap of action steps. We wanted to designate we had a designated person document in the patient record. Wanted to compliment excellent work to promote positive culture and end the case conference on a positive note. And so, Andrea, I think you're going to talk here.
Yeah, so with that being said, I mean, you know, it's amazing to me to sit here and to look at this data and to say, you know, it works. And so, you know, when we looked at the efficiency of case conferencing, it was tremendous how we were able to accomplish this and how significantly case conferencing really improved our patient outcomes, and you'll see that in the next couple of slides, but we were able to get case conferencing down to 6 minutes on average per patient. I mean, which is really, I mean, that's just phenomenal work. And, you know, I think it really comes down to the fact that, you know, we supported, we being the organization as a whole, really supported the clinician to say, this is really an important piece, not just for our partners, you know, the hospitals, but for our patients as partners. I mean, this is something that patients really, really believed in, that if they wanted good care, that good care really could be at home for them, and that's where they want it to be. And so when you're looking at this, you can see that, you know, we still had a large number of patients who were triggered as being, you know, at risk for hospitalization. But we were able to really perfect this with clinicians and you know, being able to do this in a very timely manner so that if that clinician, if that start of care happened within that first 7 days, that person was already triggered and on the case conference roster for that following Monday. You want to go to the next slide? So as you can see, the overall acute care risk-adjusted rate for Christiana Care VNA for fiscal year 15 was 19.36 as compared to national, which was 23.67. So, you know, if you recall, fiscal year 14, we, you know, the acute care risk adjusted was 25.11. So we were able to come down by 5.7 percentage points of a reduction and get down to 19.36% in fiscal year 15. And then, you know, is it sustainable? You know, were we able to hardwire it? And I think, you know, this is where it's that commitment and that dedication, not just of leadership, but also, you know, management and clinicians, it really was hardwired at Christiana. And, you know, you can see in the bottom there, you know, we went from 2511 in fiscal year 14 down to 19.36 in fiscal year 15, and ended fiscal year 16 with an acute care hospital risk-adjusted rate of 14.31. So, you know, definitely proven to be sustainable. It is, you know, you are able to hardwire this. You know, it is a process. It's a lot of work. It's a lot of commitment from the perspective of the organization, but the outcomes, I think, speak for themselves.
So we want to share with you one of our success stories, and I really would like to reiterate what Andrea was saying, how important it was to get the patient's goal, and it really helped to direct the way we did our treatments. And this is an example of a success story that we had a 68-year-old male with Mets lung cancer, and the caregiver and the patient were refusing hospice. The patient was quickly deteriorating and had a recent diagnosis with more Mets to the bone. Pulmonary function tests were declining. The patient now having great difficulty with ambulation and shortness of breath. And the patient's goal was to attend his son's wedding in 2 weeks. And the prognosis was not great that this was going to happen. So the nurse and the therapist worked with the patient to be able to keep him moving, keep him as stable as possible, and worked with the family to follow the treatment guidelines and recommendations, because the family is so important of this working out. So what we were able to do is the patient's family and wedding party, although he couldn't get to the church, they were able to come to his home the day of the wedding for the patient to be part of his son's special day, and then the patient passed away at home shortly thereafter. The family was so grateful to us that we were able to help this work out, and what a wonderful thing we did for the patient, and what the last things he did on this world. We wanted to give some information about how much we have worked with the case conference. So in this time period, we've conferenced 1,020 patients, which works out to be about 20 patients, approximately 15 to 20 patients in a week, versus the 2 that we were having impact on back when we first started this. Consistency was reached with holding case conference as a recurring mandatory meeting on Mondays on the same time of day. And we have found that we tried really hard not to cancel the conference, because we really felt that if you miss the conference, if you skip it 1 week, then people are going to forget, well, are we having it this week or are we having it next week? So we really made sure we were consistent with that. And the only time we did cancel was for bad weather or holidays. My schedule is always clear on Monday, and no one knows not to schedule any other meetings at that time, including my bosses. And complicated cases, we decided could be discussed at the end of each conference to minimize delays in other cases. For some patients, 5 minutes is not going to be enough. And so if the manager or the clinician can identify that the patient is going to take longer, we will put them at the end of the conference. And what we found, and as we're still very excited about, is that the ICM model enabled the team to effectively and efficiently conduct the case conferences. We addressed risk, we optimized the plan of care, and reduced hospitalization. The focus on the patient's data goal enabled the team to identify resources in the community, their village, to keep them at home. And the reason why we liked having these case conferences also and having as many people participating is because we could identify other sources in the home. So if we knew that getting food was a problem, then we sent them to the food pantry. If we felt that there was a dangerous situation for the patient, then we would have somebody contact Adult Protective Services. Medical social work is really a huge help in trying to work through what situations we can handle and what's out of our control. Our path forward is to maintain efficiency so that in order to increase cases reviewed, we want to increase the use of technology. We want to implement secure screen sharing. We use Link here so that we could have some video conferencing. Our clinicians tend to call in on a conference line, but it really is nice when you can have that face-to-face interaction, because the people who tend to come in to the conference in person, they tend to stay longer and listen to more of the case conferences and then offer their opinion and their expertise so we can come up with the best solution for the patients. We want to, and one of the ways we might be able to do that is if we change the location. Right now, the conference is held in our boardroom at the VNA, but if we could maybe work it with local libraries, secure a room at a local library so the clinicians don't have to travel as far and can make it more efficient for the clinicians. We want to build the strength of our interdisciplinary teams and coordination across the continuum. I know as a physical therapist, there's a lot of things that when I started doing the job, I was strictly doing physical therapy, but now I'm doing things with staple removal and medication reconciliation so that the boundaries of what's therapy and what's nursing have really blurred, and we need to really work on our interdisciplinary skills so that we work for the best for the patient. A couple other things that we want to work on is develop team members to facilitate case conferencing. This is really a wonderful development skill for someone who we want to advance to leadership or who wants to take a more active role. When someone has passion about something, it's amazing what they can accomplish. We need to continue to cultivate our community partnerships to support the patient staying safely at home. What resources are out in the community that can help the patient, especially for some of our financially deprived patients? And we focused mostly on hospitalization when we got this project started, and I think I've alluded to, we look at, I personally look at the M1800 questions to make sure we're utilizing therapy as much as possible. But we also want to see if we can impact case conferences so that we can improve our clinical outcomes, case mix weight, patient satisfaction, and employee engagement. And this is just a slide. If any of you were at the VNA conference in Miami and we did a poster presentation, this is one of the slides that we had depicted, and just to show how important it is to have the patient at the center of every interaction and how we dictate and how it can help dictate what interventions that we should work on. I think we got through this a little faster than we had expected. I hope that's okay, Heather.
Yeah, that's great. Thank you so much. We're going to go ahead and move into the question and answer session of today's call. If you have any questions, please feel free to use the chat feature on the bottom right of your screen. And we do have a few questions that have come in during the presentation, so I'll go ahead and ask those now while I wait for any additional ones to come in. The first question is, how were you able to get your case conference from 30 minutes to 5 minutes?
Well, we really, in the beginning, we weren't as comfortable with the SBAR, and so we would get a lot of extraneous information that didn't really matter with what the task at hand. So we tried to really work with that SBAR so that we could really be focused in what truly was the problem and sort out what could we solve and what couldn't we solve. Andrea, do you want to add anything to that?
Yeah, I think the other piece that was really, really significant was that we had to acknowledge to every team member that everybody's an equal, and that, you know, we needed to put our discipline aside, and we needed to be able to say that it's really about the patient. You know, we needed to be okay and to set ground rules so that if you were going off on a tangent, your counterpart or colleague could say, hey, time out, this isn't the place and time, we have to get back to what the patient wants and how do I make an impact and change for the patient. So I think, you know, setting ground rules, I think being very, very much the gatekeeper of the time. You know, you have 5 minutes, so you better really come prepared to talk about what you need to talk about in a 5-minute time frame. And I think people, because it was equal and people were very respectful, and so, you know, as somebody who was a facilitator for, you know, to get this off the ground, my counterparts had no problem saying to me, Andrea, shut up, you're lollygagging.
And I have to reiterate what Andrea was saying, is that you have to tactfully and politely cut people off. And that's one of the problems that we did find more when we went more to telephone conversations, because it's kind of hard because the patient can't, or the clinician can't see you. So they're just talking and talking and talking, and so we really have to, you know, cut them off. And I have had conversations with clinicians who, you know, tend to speak more than we, you know, that can't keep it succinct, that we need you to really kind of keep it more on focus so we can keep on schedule. Because it's not fair for the clinician who's calling in thinking they're going to be discussing their patient at 2:30, and we're not going to get to it till 2:45, 2:50 because we've taken up so much time on somebody else.
And Mary Beth, can you tell us how you've done with receiving support from leadership and the board?
Oh, that's actually a great question. As we've talked about earlier, in order to get, I have been part of case conferencing before, but when you don't have the right people in the right place and the right support from the leadership, you really have to have that support from leadership so that no one puts anyone, when Andrea was with us and myself and Naomi, no one puts anything on our schedules from 2 o'clock to 4 o'clock on Monday. And we've been so excited about this project that actually the chairman of the board attended one of our case conferences and was very impressed with what we were trying to do. And if there's anything I think my takeaway from the VNA conference in Miami was this is our time to show what we can do in the home with so much care going to the home and how we're the experts in this area. And the case conference, trying to develop partnerships with our health system, getting the chairman of the board invited to coming to our conferences, has really helped us a lot so that we can really serve our patients and our community so much better.
Well, we do have a number of other questions that have come in.
Okay.
Did you find that having case conference on a Monday rather than a Friday helps with attendance?
Andrea, can you answer that one?
Yeah, I think it did really help with attendance. We kind of set the stage. We did a SurveyMonkey prior to starting case conference. We had 5 questions that we sent out to all of the clinicians. So we actually elicited from them input as to what would be best. And, you know, the consensus was earlier in the week was better. You know, on average, looking at the number of starter cares that we used to do on a Saturday and a Sunday, it just made better sense to capture those patients sooner rather than later. So I think it was a twofold benefit for the staff, but as well as the organization.
And in addition, if there was a recommendation that we wanted to have made, we could start it the next day. If we did it on Friday, you know, we had the weekend to deal with, and then other issues would come up.
Great. Who attends each case conference? How many people?
Mary Beth, do you want to answer that one?
Sure. We typically have about 5 people in the boardroom, five to 8 people in the boardroom, and then in terms of call-ins, if we're doing somewhere between 15 and 20 patients at a case conference, we probably have somewhere between 20 and 27 people calling in at various times. We've also extended the invitation to our liaisons in the hospital. So if we have a patient that we're concerned about, that they're a frequent flyer to the hospital, so that the liaison is aware. So if we need to do conferences at bedside before they come home, so we can get a plan of care in place right from the get-go. And one other thing I forgot to mention is that when we're developing the case conference list, if someone is, or if their name is, they're already in the hospital or they're discharged, we still keep them on the list because we want to look at, you know, was it something that we missed? Is there something we could have done better? Is there something that we should have in place for when they do come home?
Okay, kind of tagging along that line, how long does it take you to identify the patients and get the list out to the attendees?
The research from SHP alerts, from pulling patients from the SHP alerts to adding them to case conference, it takes about 45 minutes to an hour, start to finish. From that point, it's just a matter of sending on the emails. Andrea?
Yeah, I was just going to say, and I think, we were very fortunate because we had the support of Naomi from an admin support perspective to really, the data's there in SHP. So she was really the person who went into SHP. She captured the data. She put that list together and got it out to everyone in a really timely manner. So by the end of the business day on Thursday, every clinician knew who was going to be discussed on Monday. So I think, the prep work, once she got her groove and really was able to export the information, and, we had to go into our EMR to then identify who all was involved in the case, because she really wanted to make sure that anybody who knew this patient or who had seen this patient, that their name was on that list, so that they would potentially participate in the case conference.
In addition, Naomi serves a very valuable role that when that a note is being put in the chart regarding what we discussed at case conference, and helps to facilitate that.
How much time would you estimate that you dedicate weekly to looking up the information on each patient?
Andrea?
That's not very funny. It varies. It really varies because, having the advantage of, I was the clinical director, so physically being in the office, you would hear the buzz of what was going on with certain patients. So predominantly, being able to triage and look at referrals as soon as they hit the door, I already potentially knew who we were going to be talking about. And then, like I said, or like Mary Beth said early on, one of the things that we very, very quickly identified was that our heart failure, our COPD, and our oncology patients probably took up 80% of our case conferencing list. So therefore, part of my hardwiring was that every single day, multiple times a day, I was looking at SHP. Our organization chose to have SHP data scraped 4 times a day. So this way, anytime somebody completed a start of care, they were triggered and alerted. So, that was just part of hardwiring the tool, so those alerts were automatically coming to me. And then, literally getting into, Christiana Care uses McKesson. So getting into McKesson and actually then diving into what was going on with the patient, that, that really varied. I mean, it could take you as little as 5 to 10 minutes or as much as 20 to 30 minutes, depending on how frequently that patient showed up on our roster.
And I also might add, for some of our complex patients, we might case conference them one week, have a list of things that we wanted to get done, call the doctor, get therapy involved, and then we would actually put them on the case conference list in another week or two to see how are we doing. Do we need to continue? Do we need to bring any other services in? Do we need to, what we also found with the patients who are at risk for hospitalization, we wanted to front load visits. So then we would look at them again. Should we keep up this frequency, or are we okay to back off because the patient is stable?
Okay, so someone asked who leads and coordinates the preparation of the case conferences.
That would be Naomi. And without her, it wouldn't happen. Because I've done case conferencing before when it was another nurse manager and myself, and it's very hard to do all your duties, especially for a Monday when things are busy, and the end of the week, that you really have to have one person dedicated to getting that list out and making sure that list gets out timely.
And then on the back end of that, I think some of the key drivers are the staff education. When you have when you instill the SBAR format into the staff, and that's what the clinicians are ready to work off of, you get so much more information ahead of time than you do actually in the meeting, and you don't get sidetracked. In addition, also ingraining the patient goal. What's the most important thing to them? Making sure they ask the patient what the most important thing is. If they can't come up with anything, talking to them and just having a normal conversation with them at the bedside to find out what it is that's important to them and what they care about the most.
Who leads the conference on the day of?
Right now, Andrea was the facilitator when she was our clinical director, and I am the facilitator now. And and I also have another nurse manager that helps me with it, but I am always looking for somebody else who would like to develop that leadership skill. But you do have to have somebody that facilitates and keeps things on track. Sometimes, occasionally, a patient may go over to 6 or 7 minutes, but then there's other patients that don't take as long. So we really are pretty efficient with staying on track.
Do you use a particular case conferencing tool?
Just the SBAR, so we can give that and people can read that.
The three key skills, or the three tools that we use are SHP, again, for our alerts, Excel to keep track of patients that we've already case conferenced on and who has discussed those patients, and the patient's the medical record in Horizon.
And I think there's one other piece that's really key, and that was the ICM training and certification that everyone went through, because really that's the fundamentals of patient-centered care, and really to get down to what is that patient's goal. So that it very much, I mean, most people, my background is actually 27 years of hospice care, so case conferencing very much mimics what hospice had been mandated to do, which was to really use that patient and that family to say, what are your goals? And then what does each individual discipline bring to the table to help you to obtain those goals? So I think that, the ICM model really instilled in us, getting back to asking the questions of the patient, how to engage the patient in owning and being a part of their plan of care, and then really to elicit, how do we get you from where you are today to where you would like to see yourself tomorrow? And then we are the tools, so the nurses, the therapists, the aides, the social workers, all of those disciplines are really the patient's tools to be able to accomplish that goal.
How do you handle housekeeping items that come up during a meeting?
Mary Beth?
Well, it depends on what kind of housekeeping items they are. If we're concerned that, in the past, I hate when I get the phone calls from clinicians that they don't know what to do with a clinician or with a patient because cert period's ending and should they recertify. And I'm kind of, well, let's put this person on case conference. The facilitator is the one who really needs to keep the person on target so that if they're talking too much or getting off track, you really have to get them right back on track. If we determine while we are working with that maybe this patient would benefit from a physical therapy assessment or a home health aide, then we'll have somebody calling the doctor right away, and we'll also be putting the order in so that we can take care of those things at the onset. And one of the things, I think somebody asked, who sends out the email and all of that, and that's definitely Naomi, but the part that I have is after the conference is over, what are the follow-up items that need to be done? A patient that was recommended would benefit from physical therapy or occupational therapy, and they don't want to have it. Is it worthwhile for the rehab manager to call and talk to them about the benefits of rehab?
In addition to that, anything that we walk away with, any to-dos that we walk away with from case conference, they're entered real-time during case conference into the patient's medical record. So if there's something there where we need to add on social work or we have a question for the occupational therapist who may or may not have been able to attend that day, all those notes are entered real-time into the patient's record, and those notes are sent to the clinicians. So they'll see those, they'll react to those, and they'll reply if need be.
And with the McKesson system, an upgrade over the past year is that you can send out those notes to more than one people. So anybody who's involved with the case, whether it's the nurse manager, the case manager, the therapist, or somebody who has known this patient in the past, they all receive the note too.
Who do you choose to include in the case conference?
That's an easy answer. First, looking at the SHIP report, and we're going to look at the people who are moderate and high alert for rehospitalization, and Naomi looks at it over the past 7 days since the last case conference. The first person she's going to put, the priority first is the people who are resumption of cares. So they're coming out of the hospital. What are we going to do? What are we going to set up? What services are we going to send out? What do we need to be thinking about to help this patient stay out of the hospital? Then she'll look at patients who actually did go into the hospital under our care. Did we miss something? Is there something we should have looked at? Do we need to let the liaison know in the hospital? Do we need to have a bedside conference at the hospital so we can facilitate having the right services in the home? What do we need to do different? Or maybe we didn't do maybe there wasn't anything we could have done. That was just the way the cookie crumbled. And then lastly, and the piece that I like the most is when a clinician calls me and, really struggling, well, the nurse wants to do this and I want to do that, and their cert's going to be up in 2 weeks. That's when I always say, write to Naomi and let's put it on case conference. And we've had an increase in requests from the clinicians for who should be on case conference. And to me, that's a really good sign because the clinicians are taking ownership of this also.
So from a care team perspective, how do you decide who participates on that side of the equation?
Well, actually, we want all the clinicians, we make sure, and in that 5 minutes, if there's 4 different services, we make sure everybody gets heard because everybody brings a different perspective to the care of the patient.
Okay. If a patient involves really only one clinician, do you also include that in the case conference?
Yes, yes. But what we'll also be looking at is what are some of the problems. So, for example, if a nurse is saying that The patient's mobility is fine, so we don't need physical therapy, but their major problem is that they can't remember to take their medications. Well, then we're going to suggest, well, do you think an SLP referral would be worthwhile so that they can work with the patient on short-term memory? So why is it that they're not taking their medication? Is it that they have short-term memory issues? Do they have fine finger motor skill problems, so we need to bring OT in? So we look at all of that.
Heather, I'd like to just interject. I think the other thing, though, with that is the population that we saw that were high risk, I'm going to say probably 90+% of the time they were not a single or standalone discipline. I think that was one thing that I think was always really encouraged from the time that referral came in, was really to identify what appropriate disciplines needed to get in there from the get-go. So there were very few times that there was a standalone discipline that the patient appeared on the case conference list. And then to go back to what you were asking prior to that about how the clinicians are included or how they get to come to case conference, when Naomi sends out that list on a Thursday, it goes to every clinician in the organization, whether that's their patient or not, because one of the things that the organization was committed to was to really getting everyone to understand the significance and the importance of case conferencing, and then even though it may not be your patient, there may be a similar situation going on that then will help you to better manage the patient that you do have.
The other value we have in case conference is we use it as part of orientation for our new employees. We want our new employees right from the get-go to understand the importance of case conference and their participation in it, because down the road, it might only be their patient. They might only have one patient, but there's other patients that are discussed that are going to enhance their knowledge and their expertise in home health.
And lastly, I'd like to add to that, as far as having all the clinicians in the room, if we have a patient that has several disciplines in the home, you may have clinicians that, because of their caseload, have tunnel vision. They go in, they see the patient, they treat what they need to treat, and they get out. The case study that we referenced earlier in the slide presentation, the patient's goal was to get to their son's wedding. We had 3 or 4 people that were clinicians that were seeing that patient on a weekly basis. And one clinician thought the patient's goal was to stay out of the hospital, and rightfully so. The patient wanted to stay out of the hospital. But by having each discipline in the room and all of them finding out at the same time that the patient's goal is actually to get to that son's wedding, they were able to work together and communicate with one another to get that patient to the wedding or have the wedding party come to the patient.
Great. How soon after admission do you add a patient to a case conference, and what specific interventions have you implemented to keep patients out of the hospital?
Andrea?
So, like I said, I think the way that we use SHP, and our data is scraped I think it's 4 times a day or around 4 times a day. So we're constantly looking at who's alerting for high risk or moderate risk for rehospitalization, and who those who is on that list that is potentially a rock. So as soon as that alert comes across, that name automatically gets filtered to Naomi to start building that list. So it's a really dynamic and moving list all week long, so that, you know, come Thursday, that list is complete and ready to go out to the clinicians. And then on Friday, if we start seeing that there are people are alerting, we may do a separate case conference on that patient, but if at all possible, we try to put that person right on the list for the following week.
And I'd also like to add, as a rehab manager, I know all of you out there know the challenges of having enough physical therapists, occupational therapists, and speech therapists. So I'm always constantly looking to see, you know, where do we need to use our resources. So this also helps me that if someone comes up on case conference or I know that it's alerting, then it helps me direct getting the services out there sooner. Because we all know that the, oh, I'm sorry, go ahead.
I'm sorry. I was just going to ask if you work with an admission team.
Well, we have our schedulers and a central intake. In central intake, we have a special coding, what we call high priority patients, and those are the ones that we're concerned might go back into the hospital, or they're right after a surgery, or the doctor's called the office and are of concern. We'll work with them and they'll let us know, and then we can assign services accordingly.
Okay. How did you get your staff to shift and stay shifted from a clinician-centered approach to a patient-centered approach?
Andrea?
That was, I think, I mean, that's,
you got the short straw, Andrea.
Yeah, I just think that, it really was, I think the passion that the management team had to this being successful just trickled down to our clinicians. And so because we said, this is something that we really believe in, and we walked the talk. And by us doing that as a management and a leadership team, the clinicians, it was really easy to bring clinicians along. Now, granted, you always have, one or two that are going to challenge or question, but as they saw things changing and as they acknowledged the fact that, hey, this is really working, so that, the statistics that we showed you today, we gave that and showed that to the clinicians on a regular basis. I mean, we would email them, colored copies of the results in SHP. Look at this. Look at this patient that had been in and out of the hospital 6 times in the last 3 months. And all of a sudden, because we went back and we talked about them and we put a plan in place and we got therapy in there and we got homemakers in there and we got all of a sudden that patient, we've kept them out of the hospital for 60 days. Kudos to you as a team. And, Mary Beth talked about this early on. We tried to end our case conference on a positive note, but we tried to all day long, every day, we tried to really acknowledge the positives that were going on because of case conferencing. And it could be a one-on-one conversation, or it could be that we had a couple of clinicians, in the office documenting, myself or one of the managers, or even, Jen, our branch director, would walk over to that group and say, wow, you guys are doing an awesome job. We are down to this percentage for acute care hospitalization. So we constantly kept the clinicians engaged.
And I just finished, we just finished our performance appraisals here, and although I didn't hardwire it into one of the criteria for their rating, but I did talk about performance evaluation and how, and did acknowledge the people who did participate and try to find out with others, why aren't you participating, or what can I do to make it easier for you? And it seemed to really was more with our part-time staff. Full-time staff is pretty easy to get them engaged. It's the part-time staff, depending on when their day off is, that's a little bit more challenging.
So how did switching to this case conferencing method impact productivity of your staff?
It improved it, if anything, because then the patients had, or excuse me, the clinicians had a direction of what they needed to do with this patient, so that instead of having to make 7 different phone calls, we had it all taken care of during case conference. And if the manager needed to step in to help make phone calls, facilitate someone, call a doctor or get something involved, we helped the clinician with that. And that's the beauty of having the conference only being 5 minutes, because all we're doing is asking you to take, 5 minutes out of your day. And the other thing we did for efficiency too is we group the patients according to the case manager, so that you don't have them having to call in for a patient at 2 o'clock, 2:25, and 3:45. It's all grouped together, so we're not disrupting their day.
So do they call in to the case conference at staggered times depending on when their cases are expected to be heard, or do they call in for the entire case conference period?
That normally depends on what the clinician schedule is for that day. The majority of the clinicians will call in or come in, and they'll stay on for several case conferences and give any input that they feel they can provide to any patients or any case conferences. And we have some that if they have an extremely busy day, they may just call in for that 5 or 10 minutes that they need to discuss their patients.
And that's why it's so important for us to stay on target with when the patient is going to be discussed. And we've been pretty successful with that.
So you showed data on the improved readmission rate. Did you have improvements in other metrics?
Andrea?
Yeah, we did. We had some clinical improvements as well as our patient satisfaction. And I apologize, Heather, that I don't have the specifics. I mean, we can get that for people, but we absolutely did see an impact and improvement in clinical as well as patient satisfaction during case conference. And we also, I said earlier that we did a survey monkey to staff. We also had a improvement in staff satisfaction. So we did a pre-survey, a mid-survey, and a post-survey for staff, and absolutely staff felt they were much more respected. It was a much more engaging, and they saw the benefits. They also acknowledged the fact that they had a better appreciation and understanding of what the other disciplines could bring to the table.
Great. Did you have any other readmission reduction efforts going on at the same time as this initiative?
No, we didn't. And this, and we talked about this because, with healthcare, it's a moving target. There's always something else that's coming up. There's some other focus you need to work on, or Medicare is taking away some of your reimbursement or whatever. But this is the one thing that we were really committed to, the ICM training and doing the case conferences on a consistent basis. So that's why we feel that this is a direct reflection of our decreased hospitalization. And we're well below the national benchmark. And I guess the slide to me that was most important is where we showed that we sustained it. You can do anything for 6 months, but year and a half later, if you're still doing it, that to me is we've made a difference.
Okay. Do you review the rehospitalization patients? If so, do you do it at the case conference or at a separate conference?
I'm sorry, can you repeat the question?
Sure. Do you review your patients who've been rehospitalized? And if you do you do it at the case conference or at a separate conference?
Oh, absolutely. We do the patients that are rehospitalized, because they will have come up on our SHIP alert. And we do because we want to find out, did we miss something? Should there have been a different service in? Why did the patient get rehospitalized? And then we want to work with our liaisons in the hospital so that we can find out what's going on. Should we do a case conference in the home? Can we talk to the doctor so that when they do come out, should we have a home health aide in service? I recall one situation. It was an oncology patient that kept going in the hospital for infection. And before we could get other services out, he was back in the hospital. And we were talking to the nurse, and she really felt the reason he was ending back in the hospital is that it was really not a very clean house. He wasn't very clean. So the first thing we thought about, okay, the minute this patient goes out, let's get a home health aide in there. Let's get the occupational therapist in there who can maybe find out what is the problem with bathing more, the cleanliness aspect. And we were successful because we did decrease the number of hospitalizations for him, and we were able to keep him out longer.
What are your standard productivity expectations for staff?
I can speak to rehab. We go with weighted visits. Physical therapy is 27 units. Speech language pathology is 24, and occupational therapy is 25. Andrea, can you speak to nursing?
Yeah, so for nursing, it's between 26 and 28 units per week. And, you know, nursing, too, has weighted visits.
And keeping all of this in mind, what do you think the key to your success really was?
Consistency. That we always had the conference at the same time. We tried to get out the email at the same time. It was the same day of the week, and we really acknowledged the people who called in and the good job people were doing, especially when we had a case that was complex and we wanted to look at it again 2 weeks later, 4 weeks later, and to see the progression and the clinicians to be a part of that progression.
Where did you get your ICM training?
Andrea, do you want to speak to that?
Sure. From Paula Sutter and Beth Hennessy from the Integrated Care Management Center out in California. And I'll tell you, I think it was a wonderful, wonderful tool and a great skill set for clinicians, and definitely well worth pulling people from the field. So just to give a little bit, they actually came on site, they did an assessment of the organization, then we committed to having all of our field clinicians being pulled for 2 4-hour blocks of time. And so they did 2 consecutive half days off site. And then after that training, they ended up having the availability to do 4 modules online that they had to be tested on, and we gave them 8 hours to be able to complete that in order to get their certification.
And we now are continuing with it, but when we, with the program, it's train the trainer. So now we have it as part of our orientation for new staff members.
Great. Well, I would like to take this time to thank everyone for joining us today, and I especially want to thank our presenters for sharing their expertise, time, and commitment to making this a successful program. Thanks again for your participation. I hope everyone has a wonderful afternoon.
Thank you.
Thank you.
Thank you.